Good afternoon, dear colleagues. My name is Julia, and I'm a fertility specialist. Maybe can I pick up it? Yeah, it's better. So my name is Julia, and I'm a fertility specialist, and at the same time, I'm the head of IVF department in Moscow, Russia. So, and I'm happy to be here. And first of all, I'd like to thank organizing committee for the opportunity to deliver my presentation at this conference on the topic that is very important and the most controversial for fertility specialists. We are going to talk about poor quality embryos. It's the fifth one. Where is it? Here it is. So we're going to talk about poor quality embryos, what to do with them, to transfer them into uterus and give them a chance, or try to get better quality embryos in the next IVF cycles. So one of the aims of my presentation is to give some guidance on where to put a comma in this sentence: transfer, not discard. So this presentation was prepared without any support from any financial organization, so I have no financial conflict of interest. But I have three other factors that should be discussed and evaluated. The first one is our desire to show as high a pregnancy rate as possible to attract new patients. We all know that when patients are searching for a clinic or doctors, they are all times they check success rate, which is on clinic website. And of course, they try to choose someone who is showing the higher percentage of pregnancy rate. That is, which is often misleading and doesn't mean at all that patients has actually got a higher chance of pregnancy. The second aspect is who is responsible for the IVF outcome. If pregnancy doesn't occur after embryo transfer, the patient will be extremely upset and have a lot of unpleasant questions to the doctors. A reasonable question as a doctor: do you want this? Because after transfer of poor quality embryos, this situation will occur much more often than after top quality embryos. Perhaps it's much easier just to start the new IVF cycle and try to get better embryos with a higher pregnancy rate. And there is a view that there is much more perinatal complication after transfer of poor quality embryos. And this fear is present in many patients and oddly enough is supported by some doctors. So the ideal path in the modern IVF world looks like this. We are stimulate the patients or the stimulation, obtaining oocytes, creating embryos, perform biopsy, then conducting genetic diagnostics and cryopreserving of embryos. And only after all these steps, we start to prepare our patients for embryo transfer. So it will be the long, difficult wait. And this way is absolutely excellent and logical, except one thing: a large number of patients will never be able to complete it just because something goes wrong along this way. And thus, their chance of becoming parents turns into zero. But there is a good news, and we can go an alternative, less common path. I think it's not so trendy right now. 5 years ago, we analyzed our work with poor quality embryos, and we were able to identify two groups of patients. The first group, when we transferred embryos at the cleavage stage or morula stage, it corresponds to the day 3 till 4 embryo development. And the second group, when we transferred blastocyst stage, it's a 5 day of embryo development, but embryologists assessed them as a very poor quality embryo. But before I show you our result, I'd like to go into more detail on what poor and top quality embryo is. The assessment of embryo is according to the general accepted criteria, which ordinarily formulated by David Gardner, enhanced many times, and currently specified in the latest edition of Istanbul Consensus 2024. So when we assess embryo, we assess intracellular mass on the top row from A, B, C, the quality of trophectoderm also from A, B, C on the vertical axis, and the grade of blastocyst expansion. So it means how is growing, how is aging blastocyst. And each embryo get its own name. So for example, the first number, it's the age of embryo, it's age of blastocyst from the 1 until 6. The first letter A, it means the quality of intracellular mass, which is inside in blastocyst. And the second letter is the quality of trophectoderm, it's external laid of blastocyst. So for example, this embryo is of excellent quality for EA, and this one for CC, it's a very poor and pleasant embryo. Everybody doesn't like to work with them. So according to this criteria, all embryos are divided into 4 groups. The first one is a top embryo, which are in blue. Good quality embryos green, fair embryos yellow, and poor embryos it's red in the red color. So, and you can see also here the different types of quality of intracellular mass and trophectoderm and the grade of blastocyst expansion. Many clinics prefer not to work with a poor quality embryos and even with a fair quality embryos. Very often it's internal policy or just unspoken rule to dispose of such embryos. So going back to our work, and I remind you, we had 2 groups of patients. The first group when we transferred embryos on the early stages in normal, and we transferred 88 embryos and got 18 healthy births. In the second group, when we transferred poor quality blastocyst, we transferred 38 embryo. We performed a 38 embryo transfer and got 5 healthy baby. So our pregnancy rate was 20 and 13% respectively. And I think you understand that we could not put such result on our website because there are success numbers woman sees on clinic website when she looks and searching the clinic where to go for. One screenshot is from clinic from North America, the second one from Europe, and the last one from my country. So our work was absolutely abnormal, I think, according to these numbers. Right now, I'd like to discuss some challenges according to poor quality embryos. The first thing, it's there is much less information and trials on effectiveness of poor quality embryos. We really don't know how different poor quality embryos are implanted and what kind of embryos are never implanted. Assessment of embryo is still subjective and depends on specialist experience and the training they receive. The second one, the mainstream for today is to transfer only one embryo to reduce perinatal complication, and it's absolutely perfect way. But maybe for such embryos, it's still relevant to transfer more than one embryo, and we can improve pregnancy rate without adding any perinatal complication for women and for newborn. We all know that each manipulation gives additional risk for all embryos and for poor quality embryos especially. So maybe it makes sense to transfer these embryos in a fresh cycle without vitrification and subsequent thawing, or to transfer them in the early stage, as we did it in our trial, not to give them a chance to stop during next 2 days until day 5. It's very difficult to estimate what is more expensive for women to transfer embryo with 15%, for example, probability of pregnancy, or to start the new IVF cycles. We really don't know whether she receives the pregnancy with this probability or we receive better quality embryos. It's really unpredictable way. That's why it's really difficult to count what is more expensive or what no. Sometimes embryos develop slowly, and we receive our blastocysts not on day 5, but maybe on day 6 or 7. The slower they are, the worse outcome is. But I don't think that it's a significant argument to discard this option completely and not to give it a chance for these embryos. We have, all fertility specialists have a very strong protocol how to prepare endometrium for embryo transfer. So hour by hour, step by step, we all know this strong way. But maybe for such embryos, there is absolutely different way to prepare lining for implantation. We really don't know this one. And doctors love to discuss about stress level for patients. So the question is, what is more devastating for women? To hear that her embryo is of poor quality and not worthy to be transferred, or just not to receive pregnancy and to get pregnant after embryo transfer. Moreover, if we informed our patients about the quality of embryo and probability of pregnancy rate, I'm not sure what is more stressful for her. And I'd like to propose only two trials regarding poor quality embryos and try to explain our position concerning poor quality embryo transfer. So the first one is retrospective study of my colleagues that they conducted from 2012 until 2016, over 4 years. And they tried to find some answers on 3 following questions. Is there any difference in implantation rate and pregnancy rate if we transfer poor quality embryos on day 3 earlier than normal or on day 5? The second question, just comparing the results after poor and top quality embryos. And the last question, I think it's a more interesting question. How common perinatal complication after poor quality embryo transfer and the top quality embryo transfer? Approximately 700 poor quality embryos participated in this study, and researchers compared the result with almost 10,000 embryos of top quality. So the answer on the first question, is there any difference between early and normal time of embryo transfer? And there is no difference concerning biochemical pregnancy, implantation rate, clinical pregnancy, take-home baby, and so on. So it's a very important information for us because we prefer in all cases to cultivate embryos until day 5 and to be sure that we receive perfect blastocyst, or maybe not perfect, or maybe not receive. And even I have only 1 or maybe 2 embryos and they are not so good quality, maybe it makes sense to transfer them early without receiving additional information about the quality and the aging of blastocyst. So it's very important clinical implication for this position. If you compare clinical results after top and poor quality embryos, of course, you can see it's not surprising that all rates are much less after poor quality embryos. You see this blue, all rates are absolutely unpleasant for us. And I agree that working with the top quality embryos is fantastic. A lot of patients are happy with the work you have done, and you yourself straighten your shoulder and feel satisfied and pleasant with your own job. To work with these embryos is absolutely devastating for doctors, and it's very difficult when you have, for example, 100 patients and only 10 or maybe 12 patients get pregnant after your manipulation. If we compare the clinical outcome also after two top and poor quality embryos, we found that the most difficult position is just to receive positive pregnancy test. It's absolutely clear that poor quality embryos cannot implant with the same frequency as top quality embryos, but if they implant, the possibility of clinical pregnancy and moreover take-home baby will be the same. So the most important and most difficult things in just to receive positive blood test for the pregnancy. So the main conclusion after this work is that, of course, we understand that poor quality embryos give pregnancy with very low chances, but it's still higher than canceling embryo transfer at all and turns this chance into zero. The next, another bit of research that analyze the contribution of poor quality embryos in the general percentage of success cases. Approximately 7,000 embryos participated in this study, and researchers found that as older the woman is, as more common poor quality embryos we get. And if you see on this graph, and if you take into account that the average age of patients in our clinic is about 38, 39, 40 years old, so we should be ready that approximately from 20 until 30% of all embryos will be like that. And we should be absolutely clear path, clear position how to proceed them. Moreover, if we analyze delivery, not pregnancy, not clinical pregnancy rate, but delivering, we will see that the more older patient, the more percentage of delivering after poor quality embryos. It's very important because if you are as a fertility specialist continuing to work year by year, you will receive more patients that are older than 40 years old. And if you just will to discard these embryos from embryo transfer, every third patient will never get pregnant after this position. That's why if I have the patients who is, for example, 45 years old, 44 years old, and they have one, maybe single or two embryos of poor quality, it makes sense to transfer them without any additional manipulation with them. So in two conclusion after this, after last trial, that also found it that until now, and I think many years forward, so these embryos are still discarded instead of being cryopreserved or transferred. And the second one, that the importance of poor quality embryos is much higher for elder women than for younger. There are multiple publications about health after this embryo transfer. You remember I talked that many specialists confirmed the idea that why we should transfer poor quality embryos, because there is a much more complication for babies and for women. So I divided these multiple publications in two groups, and just the latest one, and half of these publications didn't find any difference according to perinatal complication, development anomalies, IQ of our children that were born, and so on. The other half of publications did find these differences, but this difference was mainly due to different placental characteristics and minor defects of musculoskeletal system, as was mainly due to talipes. So I don't think that we have enough proof to say that if we transfer poor quality embryo, we really get unhealthy babies more often than after top quality embryos. So, and I could formulate only 3 take-home messages. I think 2 of them is well known. So I add only the third one. So the first one, that of course, in the modern world, we should admit that we want to be successful doctors, especially in the eyes of our patients. Of course, I have a high pregnancy rate, and you can see my on Instagram. I'm a very successful doctor. However, this desire should not lead doctors to be being selective who to treat and who to reject. It's concerning about the patients, and everybody knows this position. So, and even more so, it should not lead doctors to making a categorical choice just because it doesn't look exactly how it should by the book. And this is about our embryos. We know much information about quality, development, and blah, blah, blah about our embryos, but we really have no position how to predict do we receive pregnancy or not. So, and just reminding, just maybe we can imagine the conversation between these two boys. The first one, what were the odds of you being born? Oh, it was 12% for me. Hoops, it was 54 for me. So, and thank you for your attention and for your time. And this is my colleagues that helped me to create this presentation. If you have any comments or questions, I'm happy to answer this. Thank you.